Okay, let's continue on. We're going to look at trauma. Trauma to the head. So, when there's acute brain trauma or an insult to the brain itself, it could be blunt force trauma or it could even be open trauma. How would be open trauma? Well, if the skull was compromised, in a traumatic event, and then there was a secondary injury, it could directly influence the brain itself. Or there could be surgical induced trauma that does happen, right, where the surgeon's has removed the skull cap, is working in the brain, and does damage, open damage, because the brain is accessible. But more commonly is going to be blunt force trauma, a fall or a strike to the head. And in a head injury, a coup injury occurs underneath the site of the impact of that object. And then the contra coup injury is occurring on the opposite side of where the head was impacted. And the reason for that is you have to remember that the brain itself is floating in this cerebral spinal fluid. So if you strike the head here, that brain is going to recoil and can hit the back side of the skull cap. So if there's a frontal strike, that brain can recoil and cause a contra coup injury on the back of the skull. Okay? Or opposite, strike to the back of the skull, the brain flies forward and the frontal cortex smacks the inside of the frontal bone. So coup and contra coup injuries. Okay, so you kind of have to look at both when you're dealing with trauma. You want to make sure that you're not just focusing on one versus the other. Okay, so this is a case study. Over the years, we get a select number of students that actually have the opportunity to do these case studies at the County Medical Examiner's office. It's on the student, they arrange it, they just co-register with Bio 408, which is field work. And so this was a case that came up that I got permission to share with you guys. It's all HIPAA compliant. We won't talk about specifics, identifying specifics. But this is a 20-year-old Caucasian female tourist who was on antidepressants, Zoloft, and was dizzy and fell on the back of her head. She expired on the way to the emergency department with pre-death seizure activity, and questions arose to the cause of death, whether it was brain trauma or whether it was seizure. So, young tourist, okay, going down 89A, down between Flagstaff and Sedona, that Oak Creek Canyon area, was dizzy, pulled over. She was actually taking her boyfriend Zoloft, so it wasn't for her, which is not a great idea, because maybe it was the wrong dose, maybe she was smaller, she shouldn't have been having as much, felt dizzy, immediately got out of the car, fell onto the asphalt, okay, your age, strikes the back of her head and dies on the way to the emergency department. Okay? Head trauma can be pretty serious. So post-autopsy, we see that the occipital lobe had hemorrhage and induced hematoma, and there was a contra coup injury to the frontal lobe. And so the cause of death was determined to be brain trauma and induced death, not just falling from basically this position to the ground, struck the back of her head, and then also the brain lunged forward and struck the frontal cortex. And it's very, very possible that it was the contra coup injury that took her life, okay? Because that's all that motor function that shuts down, and who knows where else there was trauma. Okay, so just an example of a case study on the coup contra coup injury that took place right here just outside of Flagstaff. All right, continuing on, diffuse versus focal brain injury. So diffuse axonal injury, known as DAI, this can actually occur without any blunt force trauma whatsoever. So unlike this tourist injury that we just talked about. But it usually involves acceleration or rotational forces. So the scenario that would be most commonly associated with this would be this shaken baby syndrome. Okay? So unfortunately, there are a number of these cases every year where, sleep deprived, maybe slightly depressed parents, mothers and fathers, can't get the infant to quiet down and end up kind of being a little bit overly aggressive just out of desperation. And it's enough of a acceleration, deceleration motion in very young, friable axons that can actually cause this diffuse axonal injury. So what takes place, you can see the picture of the normal axon that's shown here on the left. And these axons with a rotational force can begin to shear. And as they shear, they can actually permanently scar off, die, and compromise the neuron itself. That's diffuse. Focal injuries that we're going to shift to. Focal injuries involve trauma or a damage to a very local area versus diffuse. This shaken baby syndrome is happening all over the brain tissue itself. So these are grossly observable as contusions or concussions, hematomas, and hemorrhages. And so as we move into this, concussion is kind of where we start out the lecture with my youngest. Okay, it was a mild concussion. This is defined as a reversible altered consciousness. Okay, that's pretty loose. What does that mean? Well, they seem a little bit out of place, not really acting themselves. That's not their normal conscious behavior. And then it can go up from there. They can't remember their name. They don't know where they are. They're having trouble seeing. She was having trouble seeing. That's how I knew that there was probably a mild concussion. Sensitivity to light. She didn't want to open her eyes. Her eyes were tracking just fine. She did not have amnesia. And the pathogenesis here is unknown. We don't know why. We don't know why this happens. But the brain gets shocked, and likely those axons are stunned momentarily, and it takes a period of time for them to reset. And it could take a day, it could take a couple of days, it may actually happen in hours. And there's different levels of progression. But the most important thing with a concussion is that there is no contusion. So what is a contusion? There's no actual damage, physical damage to the brain tissue or the parenchymal tissue of the brain. So you can see the stats on this pie chart. Causes of concussions in children. Struck by an object, so that's where my daughter fell into that category. Collision, a fall. I've had 2 kids fall in this category. Assaults are pretty low. Struck by another person. I don't know why struck by another person and assault is not. Whoops, sorry. It's like on accident. I don't know why those are 2 different categories. But I guess some statistician thinks they are. So what's a contusion? So a contusion is where you actually have lesions that happen in the brain tissue. This is definitely more severe than a concussion. How many of you have had a concussion? Okay. Fairly common. Fairly common. I've had one. I've had a couple. Right? It's pretty common. The repeat concussions can be dangerous. And you can dive deeper into repeat concussion injury if you look at, study boxers, you study football players. A lot of this new information is coming out these days. There's actually some great kind of public awareness movies now out about, head trauma to athletes. But a contusion is a very different scenario. Here you've got necrosis, laceration, and bruising. And in this particular image, we've got cerebral trauma. We've got contusions present in both temporal lobes. You can see on the right and the left, temporal region. There's areas of hemorrhage and disruption. Hemorrhage being blood that's left the vascular supply. So the most obvious one is right here, okay? But you can see areas right here. This one's pretty obvious. You can see one right here. There's some areas right here. There's some areas here and here where you've got hemorrhage and tissue disruption. Next up is a hematoma. Hematoma is defined as a localized accumulation of blood. It's otherwise known as a bruise. How many of you had a bruise? Anywhere? Yeah, I mean, pretty much everybody has, right? So the vasculature gets disrupted, the blood leaves the vascular supply, and then it coagulates, and it forms this nasty-looking coloration underneath your skin. Well, if that happens in the brain tissue, that can put a lot of pressure on the brain because you have the cerebral cap, right? You have the cranial cap. You've got the skull that's holding all that in place. So there's 3 different types of hematomas that we can see. We've got epidural, subdural, and subarachnoid. The subarachnoid is the one that's most commonly seen with a contusion. So if you've got it, so these are not mutually exclusive categories. Could you have a patient that had a concussion that actually had a contusion? Yes, you can. And if somebody has a contusion, can they have a hematoma? Yeah, they can. And so they're not mutually exclusive categories. They actually can fall into each other's category. I was going to say bleed into each other's category, but that seemed a little bit inappropriate. So the epidural, if you look at this upper right picture, you can see that epidural is usually perfused by arterial blood, whereas the subdural is usually perfused by venous blood. So in this picture right here, this is our dividing line of our superior sagittal sinus. This is the epidural picture. This is the subdural picture. So there's a tear, right? So there's a tear where you've got the dura peeling away from the base of the skull, and this is leading to arterial blood feeding the hematoma. Over here in the subdural space, you can appreciate that the dura is still attached to the underside of the skull. This red line is the dura, and the inner membrane is peeling back, and this is leading to a perfusion of venous blood. So venous blood is typically what is perfusing a subdural hematoma, and an epidural hematoma is usually arterial blood. You can see a picture here of a hematoma that's taken place, or has taken place. This is an epidural hematoma, so that is arterial blood. That is just below the skull cap. And then our last category is a cerebral hemorrhage. Cerebral hemorrhage is usually due to a significant vessel rupture, and this is a large amount of blood. Cerebral hemorrhage typically leads to death. It's unusual that someone would actually survive this. Vessel ruptures itself, the causes could be numerous, but the main causes or the main culprits are hypertension, high blood pressure, arteriovenous malformation or an AV malformation. That means where the arterial side meets the venous side, and there's an odd anatomical transition that is weak. It has a weak point. And the arterial blood is usually higher pressure than the venous side. And so at that malformation is where you've got inappropriate anatomical structure to accommodate what that blood flow pressure is going to be over time. Saccular aneurysms. Another defect that takes place, it's very common that it's associated with genetic defects. These saccular aneurysms form in the pressurized vessel when the wall of the blood vessel is compromised. That deteriorates with age. There are certain cases of patients, there's a syndrome known as Marfan syndrome, and there's an abnormality in certain collagens that are produced that make up the structural integrity of the vasculature. And without that structural protein present, under pressure, the blood vessels tend to swell or bulge out. And so patients that suffer from a lot of these types of genetic abnormalities are at higher risk of developing these saccular aneurysms. I saw a couple questions.
So is this kind of like a brain aneurysm then?
Yeah, this is a brain aneurysm, but it's of the vasculature.
Of the vasculature.
Yep. Yep. Somebody else? Okay. So you can see here on the circle of Willis the different types of saccular aneurysms and their prevalence. The highest prevalence is right here at the level of the anterior communicating artery. And so 40% of these saccular, and they're called saccular aneurysms because they literally form like a bulge or a sac. The other type of aneurysm is known as a fusiform aneurysm. And a fusiform aneurysm, usually instead of a bulge on one side, it actually kind of, the whole vessel kind of bulges out, not necessarily symmetrically, but on both sides, not just on one side versus the other. Okay? It's a lot more common in the brain that they're going to be saccular in nature. You usually see the fusiforms in the aorta, either in the thoracic aorta or the abdominal aorta. So you can see 40% of these saccular aneurysms happen here at the level of the ACA. The next greatest one is at the middle cerebral artery at 34%. After the aneurysm ruptures, then you get a hematoma because you have a tremendous population of blood that's going to clot. And then the other way that you get hemorrhage is with a massive contusion. And if it's a massive enough contusion, like what you see here in this upper right, obviously it's going to be lethal. This picture down here is showing an arrow that's pointing to a saccular aneurysm within the circle of Willis. So this vasculature should be connecting from here to here, and the thickness of this vessel is what this thickness should be, and this is bulging out in a saccular aneurysm right at the level of the ACA. Okay? Some additional pictures of what this looks like. So in these pictures, this is the image that you just saw. A little bit more clear, I think, and you can kind of see this bulge. This is an image of a histological prep of a vessel with this saccular aneurysm. So here's the inflow, and here's the outflow, and here's the bulge. Histologically, you can see the inflow here, you can see the outflow here, and this is the bulge of the dead end sac. You can see some clotted blood at this end right here. And so like what I was telling you, some of these other technologies that are endovascular approaches now are looking at ways to fill this void space. So you can come in here and cross over and put in a stent graft that blocks off this entrance. It's basically like a stent with a tube, and you will no longer perfuse the sac. Or you come in here and you can inject a polymer like Dr. Becker's lab is doing here at the university, and they'll close off and seal up that dead end and prevent it from rupturing. Questions?
So how,
Oh, sorry, go ahead, up front and then in the back.
so how do you know, like, how would you, like, because my grandpa had a brain aneurysm, how would we have known? Like, would he have shown signs of a headache, and then we would have gotten, like, a scan?
So aneurysms are like, they're considered a ticking time bomb.
Okay.
There's no way to know if they're going to happen. They're usually, if there's a history of aneurysms in your family, you'll start getting scans as you get older.
Oh, okay.
Yeah. Now that he had an aneurysm,
Yes.
did he survive?
No, he's just like he's just in a home.
He's in. Oh.
But he's like not there, like
Oh no.
mentally.
Okay.
He's just there.
So he had an aneurysm, and now he's not grandpa anymore.
No.
Yeah. So like, is it mom or dad's?
It's my mom's.
It's your mom. So on your mom's side of the family, probably how old was grandpa when he had his aneurysm?
He was 60.
60. So they might start screening in their 40s
Oh.
and start taking pictures of the head to see if they're susceptible to brain aneurysms. That's the most common practice today. Okay, and now you need medical coverage in order to get those scans. But it's important to, you don't want to wait till you're 60 if grandpa had his aneurysm at the age of 60. So that's why in all these questionnaires they ask you, is there a history of this in your family? Is there a history of this in your family? Because you inherit your parents' genes, and so they just want to know if your parents have wrestled with the disease, there's something we can do early enough to try to catch it. And with an aneurysm, you just have to find it. There's no right, the last little section for today is on kind of this other category of brain disorders. And so we're going to walk through a few of these. We're going to begin with meningitis. So meningitis is an infection of the leptomeninges. The leptomeninges are a combination of the dura and the arachnoid mater, so those coverings. This is a picture from underneath the brain. So an inferior view, this is the cerebellum here. This is the underside of the cerebrum, and the brainstem is kind of, this is the tip of the brainstem, and the brainstem is covered by this white mass or this pyogenic infection. So that's pus, in other words, okay? The symptoms commonly with meningitis are headache, photophobia or sensitivity to light, stiff neck, irritability, flu-like symptoms. People generally feel lousy, they have malaise. The causes could be either bacterial, fungal, or viral. All three can cause meningitis. The acute pyogenic meningitis that you're seeing here is that pus, and there's two main categories of bacterial meningitis, right, which tends to be the most common. The college age students, so your age, the younger and the older tend to be affected, but the younger college age students are usually affected with the second one on the list, the Neisseria meningitis. And then the very young, like the infants and the elderly, are typically affected by Streptococcus pneumonia, the top one. So that's how these segregate out. We've had some meningitis outbreaks on campus in years past. It's common in tight living quarters, like in army barracks or in college dorm rooms, where you just get a lot of transfer of bacteria, viruses, or even fungus. Okay? And it's treatable if it's caught early, and obviously you would use an antibiotic, but you would actually have to deliver that to the leptomeninges. And so how does it get in? Well, if the blood-brain barrier has been compromised in some fashion, then that bacteria can cross over. Certain people are a little bit more susceptible to it. There are certain bugs that can cross over. Okay, so both happen. Next question, yes?
Is there a certain type of meningitis that could kill you in like a day or two? Is that the viral kind or the bacterial?
Yeah, usually the viral is a little bit more severe. Fungus is usually the hardest one to treat. Bacterial is the most common, but the most easy to treat.
The fungus is like viral?
So there's three types, right? You have bacterial, viral, and fungal. So viral tends to be the most dangerous, okay? Bacteria is the easiest to treat and the most common. And fungus is the most rare and not as severe, but again, all three of them could kill you if you leave it untreated.
So how do you, I mean, you can get it like through sharing chapsticks or whatever, but like how does that affect you? How does your blood-brain barrier get compromised?
So blood-brain barrier function is a physical barrier of the endothelium that line the choroid plexus. And so if that endothelial network is weakened in any way through sort of a pathologic, like a disease, you know, you're fighting an infection and your vasculature is a little compromised as things are being battled, or certain bacteria will mutate and they can actually make their way through. They're more infectious, or viruses are more infectious and they'll get through. So there's no way to eliminate the possibility that you would contract meningitis. There's ways to minimize it, by washing your hands and good hygiene, and changing sheets and changing mattresses, and it's more common in crowded living spaces because you just have more people per square area, and so there's more fungus, more bacteria, and more viruses that are floating around. Creutzfeldt-Jakob. Creutzfeldt-Jakob is a disease that targets the neural tissue in the brain, and it's a disease that targets the normal cellular proteins. And these proteins are called prions. Prions are basically a component of a protein, and we normally have these protein architectures in all of our tissue, even in neural tissue, and under certain circumstances they become mutated. Okay? And that mutation that takes place causes the protein to go through what's called a conformational change, and then it starts clumping or aggregating. And as it aggregates or clumps, it reorganizes the tissue that it's in. And it reorganizes it with more open spaces. So, the Creutzfeldt-Jakob has a cousin disease, which is called bovine spongiform encephalitis, otherwise known as mad cow disease. These proteins that mutate in neural tissue, they can actually be communicated from one organism to another. They can be infectious. And so if you have a cow that's infected with bovine spongiform encephalitis, the rest of the herd is at risk of contracting that disease. And the two main routes of contamination are consumption of contaminated tissue, okay? And then the other one is just spontaneous mutation of the protein in the organism, which happens at a very low percentage. So I think I have some percentages to share with you. Yeah, so the mutation rate occurs only in 5 to 10% of all Creutzfeldt-Jakob cases. And one case, Creutzfeldt-Jakob is a very unusual neurological disease with a prevalence of 1 case per million in the population. And only 5 to 10% of that 1 in a million is due to a spontaneous mutation. Okay? The rest of it that happens is because of consumption of contaminated protein. So how does the herd get contaminated from one cow? So this is pretty gross, but the cattle practices are not so clean in the world. Okay? And when ranchers will slaughter a cow, it's very common that they lead them into the slaughterhouse, and they actually release it's almost like a mouth, and it punches a hole in the side of their head and terminates them. And so obviously any of the contaminated neural tissue is on the mallets and on the floor, and so they take a component of the beef and they work it up for a food supply. But if any of the contaminated neural tissue comes in contact with that meat, now it makes it into our food supply. Well, how does it get back into, you said one cow can infect a herd. Well, anything that's not for human consumption, a lot of times is recycled and fed back to the animals. Yes. Okay? It's very uncommon in the United States for that to take place. In fact, there hasn't been any reported cases of bovine spongiform encephalitis in the U.S. The USDA and the FDA are very, very stringent. Okay, it's been reported in Europe, in Western and Eastern Europe, in England, in the UK, in other parts of the UK, like in Australia, as well as in Brazil. And so you get on travel advisories from time to time, and mad cow disease does show up in other parts of the world. And it's because their regulations aren't tight enough or aren't streamed yet, or the practices aren't necessarily what we have here in the States. Okay? So yes, if you're going to eat beef, make sure it's American beef. Okay? So what happens? Well, as those mutated proteins aggregate, they start creating these shapes in the neural tissue that form these vacuoles. And so these vacuoles are these big open spaces. So you can kind of appreciate here, these white open spaces here are these big vacuoles as the tissue gets reorganized, because normally you would have a normal protein that would form, and you've got one mutated prion or mutated protein that forms, that connects to a normal protein, and then eventually you get a mutated with a mutated, and you form these aggregates that form these cytoplasmic vacuoles. As it forms these vacuoles, that's the spongy form that we refer to. So the neural tissue now looks like Swiss cheese, and you're losing all these neuronal connections. And so they call it mad cow because the animals are acting crazy, like, mad, right? Crazy. This is a immunohistochemistry stain for the mutated prion, and all of the brown stain is all of the mutated prion that takes place in Creutzfeldt-Jakob. Okay? So Creutzfeldt-Jakob is the human form. Bovine spongiform encephalitis, mad cow, is the cow form. Okay? Multiple sclerosis. This is a demyelinating disorder. And this disorder that is manifested in patients is a type 4 hypersensitivity. This is due to the role of CD8 positive T cells. Women are twice as likely as men to exhibit multiple sclerosis or MS. It's a very episodic disorder where it has times that it flares up and then times that it's more manageable. It occurs in about 1 to 1,000 people in the United States. And what your body is doing is harboring a CD8 positive T cell reaction that's self-reactive towards the myelin that's surrounding your neurons. And so it goes and attacks the myelin, and what do you think it does to action potential speeds as the disease progresses? It slows way down. So it is a very debilitating disease. There's a steady decline in function that takes place. A lot of times there's vision loss, unilateral vision loss. Usually it's just on one side for whatever reason. Sensory and motor function impairment. There's a loss of bladder control. And these patients usually deteriorate over a period of years. The environment versus genetics. So there's a huge environment argument that takes place. And it's based only on epidemiological data. That's just data that is data that we study, that we watch, and we evaluate, and then we construct from past information. And so there's definitely a genetic component. It does run in families. MS does run in families. But the environmental data that's interesting, that's raising a lot of questions, is that there are different populations in certain ethnic groups that have a marked prevalence of MS. So the disease is especially common in Scotland, Scandinavia, and throughout Northern Europe. And in the US as well, it's more prevalent in Caucasian ethnicity than any other racial group. And so there's been some theories in the literature on the role of sunlight. And the further away from the equator that these populations or these genes came from, the more susceptible they are to developing MS later in life. It tends to be more prevalent in Caucasians and those ethnic groups that have gene pools that come further from the equator, or northern part of the globe. Okay? All right, Alzheimer's. We just have two last ones as we wrap up. Alzheimer's disease. This is the dementia of the elderly. You'll have some questions on this. This is a disease that is very difficult to deal with families. Okay, it's one where the patient stops behaving like themselves. And it's also a disease that impacts higher order brain function. So they lose memory. They forget who they are. Their personality changes. They could have been a very passive, quiet person, and now all of a sudden they're swearing and cussing, acting like a sailor, and you're just like, who is this person? It's very tough on families. Alzheimer's disease is very tough on families. It is a type of dementia. It is the most common type of dementia, but it's not the only one. So it's the one that we focus the most attention on because it is the most common. The risk factors for Alzheimer's. Age is a huge risk factor. The older the patient, the higher the chance of them developing Alzheimer's. Prior head trauma. So back to the concussion thing. Prior head trauma is not a good risk factor for future development of Alzheimer's. Females are more likely to contract Alzheimer's or develop Alzheimer's than men. There's some debate over that, and the question is it because females live a little longer than men? And so they are a large population later in life, and if men live that long, or lived as long as women, they develop it at the same rate. I don't know the answer to that. But for right now, for the purpose of the exam, say that the female gender is a risk factor, okay? Another one that's controversial is low education levels. What do you mean by that? So patients that are more highly educated, the thought is it's easier for them to pretend and fake their family out that they're not developing symptoms of Alzheimer's. Okay? There's a great video that I will point you to on YouTube. Okay? There's two twin elderly brothers, and one has Alzheimer's. He's pretty high functioning, but he's being interrogated by an examiner, trying to understand if he's got Alzheimer's. And she'll ask questions like, tell me what this is. You know what that is. Now I want you to tell me. Well, I could tell you, but why don't you tell me? Right? So he's playing this little game with her, or they'll hold up another device when that's one of those things that you use that when you're thirsty, right? What is it? So he can't remember the name for it, but he makes it a game. So because this is under exam, that patients will be interrogated to see if they're starting to develop early forms of Alzheimer's, right? And they may not want to stress their family out. They may not want to be put in a home, so they're trying to kind of pretend that nothing's happening. They keep forgetting where things are. They think, oh, well, I'm getting forgetful. But then they get lost, and now there's a silver alert. As you've seen the silver alerts on the boards. Okay? So this one's really tough. The last thing that I want to show you on this, and then I think we'll start on this slide when we come back next week, is these beta amyloid plaques. What ends up happening in the brain, and we'll talk more about this next week, we'll pick it up right here, is that these plaques start to form, kind of like a prion disease. But these plaques start to dissociate, the proteins dissociate, and they start aggregating in the brain. And instead of forming holes like we saw with Jakob, they start forming scar tissue. And that scar tissue forms and prevents the neuronal function from happening. So instead of holes in the brain, it's scar tissue or fibrosis, okay? So we'll pick it up here. I'm not going to try to rush through the next two slides. We'll start here and finish it up next week, okay? Don't forget we have 2 post quizzes on Friday. 2 post quizzes. There's some great extra videos, okay, on neural disorders that are on YouTube. You'll see them. There's 3 of them, okay? And I think you might find them fascinating. They're old school. They're from VHS tapes that I converted over to digital formats, okay? You can Google VHS if you don't know what it is.